Thank you so much, Mr. Zanga. Without wasting much time, good morning once again, colleagues. My talk is on first trimester scan. Basically, the focus is on how should we be doing it, the first trimester scan. My presentations are burdened with three main issues that I think they do affect our region. The first issue is that our women present late for booking, so that from our own database, only 14% of women actually present for the very first time to book their pregnancy before 14 weeks. Then the second issue which really burdens me as I do this talk is that there is lack of standard approach to first trimester scan. Don't worry about the others, I'll address them when my talks come. Then we also have the issue of skills inadequacy. That means for those women who happen to go and be scanned, they are scanned in a substandard way. So I do understand that in most of our regions, the pyramid is not yet turned. Most of our women come probably around after 16 weeks and so forth. That's the majority in the public sector practice. So that turning the pyramid of care probably is our challenge in our region, where we have to convince the pregnant women to come before 14 weeks so that they can benefit from the first trimester scan and all the other benefits that come with it. This is just to show you our own data from 10,016 patients, to just show you how women were dated, women who came to us in our fetal medicine units. You can see here that it is only in 14% who happen to be dated using CRL because they managed to go in first trimester. The rest could not be dated using the first trimester scan because they will present beyond the first trimester. So this is our challenge to say, can we turn the pyramid of care so that this 12-week scan can happen probably the same frequency as it happens in other regions. And to just show you again from our own data, when you looked at 13,940 patients, again, it's reflected here that when we ask the women, when did they book their pregnancy? Because it's a common question we ask all the women who come to the fetal medicine units. I want to know when they first presented in pregnancy. You can see here that 14% presented before 14 weeks. So this is our challenge. However, the 14% who come, what are we doing? Are we able to assess them properly? So I'm going to take you through a scanning protocol. This is a live scanning video, which I did 2 days ago, specifically for this meeting. I thought it's better I show real life scanning so that you can appreciate the challenges of performing a first trimester scan. So I'll be playing the video to you as I'll be giving a running commentary on the video. Let me remove the video. I hope you can see the image clearer where you are. So here we go. Sorry, we recorded after the fetal heart measurement, but we're going to redo it again as we do the TRR. So you can see that this is the CRL with the baby in mid-sagittal position, right? I'll just pull it back a little bit to just show you. This is the CRL with the baby in mid-sagittal position, and we have the tip of the nose. This baby in particular is slightly flexed. We have wanted to be just slightly opened up here at the level of the chin and the thorax. And we can see here the genital tubercle and the bladder. So that's the ideal image for the CRL, and this should be measured from the crown to the ramp. So we continue again with this live scanning. Then we see there, and right. So here we are pinpointing the nasal bone to confirm that indeed the nasal bone is present. The nasal bone is what you see, the echogenic area you see beneath the skin. Then we go on now. What else? Here we can see the the posterior fossa, where you are measuring the brainstem, then the brainstem to occipital bone ratio there. This we use to screen for posterior fossa cysts and also measure myelomeningocele. So here we go on the ductus venosus, but you can see the baby is jumping up in about. Then we try to fight with the baby. Okay, the baby doesn't want to be done the ductus. Then we we ignore the baby for a moment on that aspect. Then we go to other things. There we are. Now, the baby is not always in quiescence, as you can see. Sometimes it's jumping up and about. Now we are taking the BPD. To me, this is probably the third most important image after the CRL and the NT, because it allows us to rule out bed conditions like, let me just take it back to just illustrate a point. So this image allows us to rule out bed conditions like, let's see, yeah. So it allows us to rule out bed conditions like aloba, holoprosencephaly, anencephaly in first trimester. Because if we can obtain a midline and the two coronary plexus the way we see here, we've ruled out those bed conditions. In our region, unfortunately, we see holoprosencephaly in third trimester because most people who do the first trimester scan, they don't look at this image because of the non-standardized approach to the first trimester. Here we go again. We can see the orbits. Let's see if that's what we got there. But we could see the eyes there. The orbits. Okay, so that was the measurement of the BPD. So the BPD should be measured as part of your routine first trimester scan. So that's the BPD being taken there. And let's see what else. Yeah, the orbits. You can see the two orbits. You should always look for them. You do not want to diagnose anophthalmia in second trimester or third trimester because those conditions do exist. Anophthalmia, cyclopia, hypotelorism is a diagnosis you have to start thinking of in first trimester. Now we are at the level of the heart. So let's see, we are changing the setting to cardiac setting there. And now, right, we are putting on the colors, the color Doppler to try and take both the feeling and the three vessel of the tracheal view. Let's see. The baby wasn't easy, as you can see. It's always jumping up and about, but everything has to be checked, irrespective of what the baby is doing. Let's see. All right. So we're trying to get a V sign. Yeah. So that's about a V sign we got there. Yeah. It's not the best V sign, but we have some V sign. Then we go to the feeling. So it's always better to use color because sometimes the machine may not give you a very good B-mode image of the heart for you to be sure that there is good feeling of the ventricles. So here we can see the feeling of the ventricles. Very important. What does this allow us to do? It allows us to start screening for very bad conditions like the hypoplastic left heart, the abnormal great vessels, because you are going to fail to get these images if there is abnormal arrangement of the great vessels and also abnormal chambers formation. This will allow you to bring the woman early, probably at 16 weeks, to do a detailed examination of the baby's heart. Now we are checking three vessels. You can see at the level of the bladder, where we are demonstrating that there are two umbilical arteries in the bladder. The bladder should always be checked because you could potentially miss bladder extrophy. So if you don't see the bladder first trimester, you have to bring the patient back and recheck again. If you don't see it, then probably you are dealing with bladder extrophy condition. Here we are taking the femur. We take the femur as part of our protocol from the FMF. We do take the femur. There we are. So let's see, there is the stomach. Stomach should always be checked. Now we are doing tricuspid regurgitation. This is not the ideal condition to do it, but sometimes the baby doesn't give you what you would need. So here we're taking the tricuspid, we are putting the calipers, 3 millimeter is the diameter of the gate there. and we are putting it across the tricuspid regurgitation with 1/3 in the atria and the 2/3 in the ventricle. Let's see. This was a slightly naughty baby, right? You can see it's always jumping up and about. But let's see. There we are trying again. This is the fights that we sometimes go through in trying to get what we have to get. Here we go again. In this case, of course, we passed this baby is not having tricuspid regurgitation, but the image of the tiara is not the best I did here, but we had to finish the scan. Okay, then we go now. We go and try to get what? Let's see. We go back to the doctors. Remember, we tried the doctors first time and it didn't succeed. You don't have to spend 3 minutes trying to get a doctors. If the baby is not posing for it, you move on. So now we are back for the doctors. So there is the doctors. Oops, we didn't get it there. We try again. All right, I'm sorry my video is shaky. My recorder was a little bit shaky, but there we go. There is contamination here. Then we try again, but the baby is not giving us time to do things properly here, but we have to fight. There we go. So we are getting the doctors now. Is there a reversal there? We check again, we double check, because you always have to double check things. There we are. There we have it now. We think we got it here, and we're not convinced that this baby had a reverse A wave. Then there we are correct now, putting the waveform in the proper position to measure. All right, there we got it. So we have our doctors. All right, well, we're still trying to get it again. You can see we are very persistent, right? We don't easily give up. Because first trimester scan will require a lot of your patience to get the right parameters. Right, so yeah, so now the baby is jumping for the nuchal. You saw what the baby did. There is the nuchal, this is the amnion. So you have to be careful when you are doing the nuchal to make sure you don't measure the amnion here. So there we go now. So there is the nuchal, we have it. We saw the baby jumping, and the baby was able to separate itself from the amnion. We are not strictly sagittal. As you can see, there's a zygoma bone here. But let's see, I think we double check. There we're just checking two portions, see which one is thicker of the two. The baby is now turning, or probably come back to the nuchal, I'm not sure, but let's see what we did. This is the condensation, the abdomen. Very important, because that's how you rule out gastroschisis, exomphalus. In first trimester. Of course, exomphalus, you have to be careful. It has to be beyond 12 weeks. Otherwise, you may bump onto the physiological exomphalus before 12 weeks. There we go again. What are we checking here? We're just trying to confirm the V sign, I think, because we're not very happy with the one we had. But let's see what else did we do there. Right. Okay, we just demonstrated the stomach, that the stomach was seen. Now I think we're trying to sort about the shaky video. Okay, double checking the nuchal. As you can see, things have to be double checked all the time to get the best of the image. This image for the nuchal is perfect, as good as FMF recommends it. This will pass the certification. Great. So yeah, let's move on. Why do you darken the skin to us for what? Okay, we're bringing it back there. Let's see. Okay. So we've done we can see we've done all the parameters for screening for Down syndrome. We're now checking the anatomy, completing that. We're checking the legs there to make sure all the 3 segments of the legs are there, and also looking at the ankle. And now we're checking the upper extremities. Just make sure we don't routinely count fingers in first trimester, but if there is need, if somebody comes and tells us that, look, there is a risk of genetic syndromes and so forth, to make effort. But we normally do count fingers in second trimester. So, but we check the segments, make sure there are 3 segments of each upper extremity. I think we're almost done there. We're checking the retronasal triangle to rule out huge palates. It's always tricky for the retronasal triangle there. Let's see. What else are we checking for? What else are we checking for? Let's see there. All right. We're looking at the skin covering the spine in this case. So we're just trying to demonstrate that the spine is nicely covered. Sorry. I think I need a laser pointer there to just, okay. All right, so it's looking at the spine area there to just be sure that the spine is indeed okay. All right, and we also wanted to check the kidneys here. Let's see, did we? The genital tubercle, the feature gender. That's what we were just pointing to there. Right, let's see what else are we doing there. I think the kidneys, we couldn't get the baby to see the baby from the back. So with the baby, as you can see, this was not an easy baby. We're checking the kidneys, the baby's kidneys, which were demonstrating there that indeed there are 2 kidneys. Right. The spine is coming from the back again here, and we see the 2 kidneys. Not as clear as we have wanted them for this demonstration, but we're convinced that the baby had the 2 kidneys. Right. What else? I think what is left now is the demonstration of the placenta. So yeah, the placenta in this case was anterior. The uterus was slightly a little bit too unvetted. That's the code insertion on the placenta there. We are demonstrating for this anterior placenta. We don't make it mandatory for our patients to have full bladders, even first trimester, because if we have challenges, we can always do the internal scan. So we don't really ask our women to fill their bladder too tight. There we go. So that's the uterine arteries here we are taking, because we do uterine arteries for all the patients, part of screening for preeclampsia. So yeah, so that's the uterine artery. You can see the velocity is more than 60. Then now we are measuring, there is a value, 2.72. We use it in the FMF algorithm for screening. We do not just use an absolute mean value in first trimester. Then that's the left uterine now, I think we are doing. I'm sorry about the shaky video. My recorder, I don't know what happened, but this is the other uterine. You can see on this woman, the values are quite high, but we're to screen using the variable algorithm, the FMF algorithm for screening. Right, so the uterine arteries are done. Basically, I think it should be done. So I think we have checked everything that we do as part of our routine first trimester scan. The reason why I decided to show you as a video, I just wanted you to appreciate that it's not an easy scan, but it can be done even on difficult babies. There's a lot of patience that is required, and also learning. Sometimes teaching yourself is extremely difficult. Go to a center that know how to do it and learn how to do it, and be very extremely patient. This is not a kind of scan you can say you have 5 minutes to do it and you want to do it in 5 minutes. In our case, you can see we did this probably around 10 minutes to 12 minutes to finish the scan. I think we were lucky with this baby who was stubborn, but sometimes it may take you more than 20 minutes if the baby is not jumpy. The jumping motions of this baby actually added to the advantage, because the baby was flipping over and allowed us to check the whole 360 of the baby. But sometimes babies may not move at all, and you may have to ask the woman to do some star jumps. You may have to ask her to go to the loo and empty the bladder if it is too full, and so forth. So sometimes it takes longer, but patience is key in trying to achieve. Just to round up my presentation, just remember that an increased nuchal translucency may have these following yields. in terms of evaluation. Sometimes, yes, if it is high, you could have chromosomal defects, but you could also have babies who come up with normal karyotype, and you have to know what to tell the parents. Because sometimes you do karyotype, amniocentesis, and the karyotype will come back as normal, and the nuchal is abnormal. But you have to be aware that the other major defects have to be ruled out. If they are ruled out, this is the alive and the figures. So it's not always doom and gloom to say if the nuchal is abnormal, everything is, over for the pregnancy. Because one of the challenges that we had when we started to practice fetal medicine in our country is that some colleagues would just basically choose to terminate the pregnancy based on a report of the nuchal translucency without even ordering further investigation, like doing an amniocentesis. But remember, you could do amniocentesis and the baby could come back as normal. We have cases like that, whereby the nuchal was abnormal. We went on to do amniocentesis, and the amniocentesis come back as normal, and the babies are alive and well. So an abnormal nuchal translucency has to be investigated to its end. So you don't make decisions just because a nuchal translucency has been done, it's abnormal. An investigative procedure has to be done, and it is based on this procedure, and also a detailed anomaly scan has to be done. Then from there, the woman can be cancelled accordingly. Then I think I've already said this on the handling of the nuchal translucent to say if it is abnormal, what is it you should do? In our unit, what do we do? If it is less than 95%, we normally offer the woman combined test of fetal self-reading test. That's our screen algorithm. But in the public sector, it's mainly the combined test that we offer. But in the private sector, we also offer them the option to do fetal self-reading test as part of their screening. But if it is between 95% and 99%, we nowadays we highly recommend them to do fetal self-reading tests to just make sure. And we also order the torch and we bring them for fetal echo if we don't see an abnormality on the fetal heart when you check it in first trimester. I think you saw on our video how we check the fetal heart in first trimester there. Then, of course, if the fetal self-reading test is high risk, then we offer them amnio. Then if it is greater than 99%, we still offer them fetal self-reading test, but we nowadays rarely recommend that they do amnio, because fetal self-reading test, even if it is normal, for you to really reassure somebody with an abnormal nuchal translucent and tell them everything is normal just because fetal self-reading test, which is testing for trisomy 21, 18, and 13 is normal, we think it is proper to just do conventional karyotype and also order chromosomal microarray to try and pick the smaller deletion duplications which may be missed by the resolution of the conventional karyotype. So this is the handling of an abnormal nuchal translucency. So to colleagues who are still using the nuchal translucency as the only parameter to screen, because it's still happening in our region where other people just order the nuchal translucency in the end there. I think it is proper to offer at least a combined test. If it is not available in your region, I think you should champion for this kind of service. We will share with you our experience of how we have managed to champion for this service, because initially they were scantily available when we talk about fetal medicine progress in Africa. I think my time is almost up, but this is my last slide. So to again remind you that first trimester scan will also allow you to pick the major fetal defects like anencephaly, the holoprosencephaly, as well the alobar holoprosencephaly, the large exomphalus. Be aware of physiological exomphalus before 12 weeks. And you may also happen to pick large myelomeningocele and megacystis. So you may pick these in first trimester scan if you scan according to protocol, as I just demonstrated on the video. Then whenever you pick up these defects, always remember that the risk of the woman automatically changes according to the defect that you've picked. So if you pick up that there's holoprosencephaly, honestly, clinically, there's no reason for you to say you want to do a combined test. What you have to do there is probably an invasive test. CVS in first trimester or an amniotic in second trimester, if the parents wish to know the underlying chromosome abnormality. The same with the diaphragmatic hernia, the same with the AVSD, exomphalocele megacystis. So the role of screening ceases the moment you pick up these defects. What you want to do now is to diagnose the underlying chromosomal defect. This is my last slide, and I want to thank you so much for your time, and I want to thank our team, the Fetal Medicine team, the team at the Fetal Medicine Foundation Zimbabwe who are hosting us today, and also the team at my clinic. Thank you for listening.